So thanks everyone for your participation today. We're excited to collaborate yet again in the VICToRY trial. And so I'm Darren Hyland, the principal investigator on the trial. And again, super excited to be working with you and your team. My goal today through these first sessions is to give you some overview of the trial and the trial design. I want to begin by just, reminding you that we're centered in Kingston, Ontario, Canada at Queen's University. I run the clinical evaluation research unit there. And for those of you who are dietitians, you may know a little bit about our work, our background. We have a website, criticalcarenutrition.com, where we house all our research projects related to critical care nutrition, quality improvement work, and systematic reviews to the literature, of which vitamin C has been one that we've been updating and publishing on over the last few years. I want to acknowledge at the outset that I am flanked by two other principal investigators, Lee Cancio from JBSA Fort Sam Houston, Texas, a burn center down in San Antonio, and Dr. Christian Stoppe, an anesthesiologist at Würzburg University in Germany. The other person on the call is Maureen Dansero, who you have had some interaction with, at least by email, and she's the project leader. There are other project staff in Europe. Michael and Ellen, you may or may not see them on email, but they support the European side of the trial. I want to also acknowledge that this VICToRY trial builds on the foundation we laid when we conducted the Re-Energize trial, which was the largest trial ever done in burn patients, 1,200 patients in more than 60 burn units, where we compared glutamine versus placebo. And that manuscript actually has been accepted at the New England Journal of Medicine, will be published hopefully within a few months. And so this isn't our first rodeo. We've been doing this trial for some time now, or collaborating as a burn research network for some time now. Grateful that you were part of Re-Energize and now will be part of VICToRY. And so we're working with same sites, plus brought on new ones. And to date, we've activated 8, and I have about 40 in progress. We aim to randomize 666 patients. I think we're, as of today, at 28. So we're just in the early phase, getting started. I'll say more about the inclusion criteria in a subsequent, more detailed slide when we review the eligibility. We're randomizing them to high-dose vitamin C for 96 hours or placebo, and our primary outcome is PODS plus death. And again, I'll say more about the intervention. I'll say more about the outcome, just showing you sort of an overview schema of the trial design. I think for this rest of this starting session, I just want to talk about the why, why we're doing this trial. And I don't need to say much about the burden of illness that severe burns has for people who experience severe burns, considerable morbidity and mortality. And we look at vitamin C as something that has potential for improving their outcomes. As you know, severe burns is a disease of oxidative stress and inflammation. Vitamin C is a very powerful antioxidant, and it's also involved as a cofactor in a number of substrates that may be useful in dealing with a burn injury. It's a cofactor for catecholamines, and so to the extent that a burn patient may be in shock, it will help with blood pressure control, reduce requirement for exogenously administered catecholamines. It's also a cofactor in collagen and carnitine, things that will help with wound healing. It's also very important in regulating microcirculation, which will also help with blood pressure, with wound healing. And so there's a lot of putative benefits to vitamin C, including enhancing immune function. So to the extent that a burn patient's at risk of infection, we may see reduced infectious complications associated with giving vitamin C. As with other critically ill patients, burn patients, when you look at the plasma level of vitamin C. They have low levels in the blood. And they, on the left-hand side of the screen, you see a number of reasons why a burn patient may have low levels of vitamin C. We know that those low levels are associated with severity of illness. So the sicker you are, the more likely you are to have a low or a lower level of vitamin C. Is that deficiency simply an epiphenomena, or is it driving, you know, an impairment or a disease process? And we do have observational level of evidence that the lower your level, the worse your organ failure. And so that is what leads to the notion of supplementing vitamin C and giving it back exogenously. The work on this actually started in burn patients more than 2 decades ago in this small pseudo-randomized trial of 66 milligrams per kilogram for 24 hours as a constant infusion. And this led to less fluid required during that resuscitative period, greater urine output, and less embarrassment to the lungs, or less perturbation of oxygenation. And so again, maybe giving vitamin C through that resuscitative period reduces the fluid requirement, tightens up the vasculature, and supports organs better downstream. As we were doing the re-energize trial, we surveyed sites and found that, well, not everybody was using this. Less than 10% of sites sort of had adopted this protocol based on that evidence of that single pseudo-randomized trial. In fact, some sites that were using this infusion did retrospective analyses and showed that, oh, you know, maybe we're seeing worse outcomes, in particular with this continuous infusion, a higher incidence of renal failure. And so there was really a call for more data. Now, that was the only trial randomized, or actually pseudo-randomized, as they were randomized by month, that occurred in burn injured patients. But for those of you who have some exposure to the literature in the general ICU patient population, and more specifically patients with sepsis, there's been an explosion of randomized control trial, and there continues to be. And they've been summarized in several meta-analyses, including one that we published earlier this year, looking across those trials, which now are all out of date, by the way, because we've had more publications, which I'll review here in a second. But at that time, looking across all those trials, there seemingly was a consistent signal of benefit from vitamin C, that when higher dose trials using higher doses were compared to lower doses, that higher doses seemed to have a greater treatment effect. There was no benefit to combining vitamin C with thiamine or hydrocortisone or anything else. And there weren't any other safety issues either. So that was a conclusion as of maybe a couple of months ago. But then we had another publication, a single center trial of 124 patients with sepsis. And uniquely, this trial used a constant infusion as well, 100 milligram bolus followed by 250 milligrams an hour for 96 hours. And although the authors concluded it made no impact on mortality, which was rightly so, as the p-value there is 0.1. But if you look at the mortality rates, the difference is about a 14% absolute risk reduction with treating with vitamin C. Again, it didn't have statistical precision because of the small numbers, but certainly consistent with a beneficial signal on mortality with the continued administration of vitamin C. However, as illustrated on the bottom of the slide, there was an increased incidence of renal failure with this continuous infusion. Now, we're not using a continuous infusion in the VICToRY protocol. We're borrowing from the work done by Barry Fowler in sepsis, where he randomized patients to a low dose, 50 milligrams per kilogram per day, or a higher dose, 200 milligrams per kilogram per day, given in divided doses, and showed clearly that if you give a higher dose, you're going to get greater restoration of the plasma levels, but that increased plasma levels, the higher dose, was associated with a greater resolution in the SOFA scores. That's the red line. So you resolve your organ dysfunction better, and that's also associated with greater reduction in markers of inflammation as judged by C-reactive protein and procalcitonin, and greater resolution of markers of vascular injury as judged by thrombomodulin. And so Dr. Fowler and his team went on and did the citrus ALE trial using that higher dose, which is exactly the dosing structure that we're using. And that would be 50 milligrams per kilogram every 6 hours for 96 hours. Now, again, in this patient population, which is acute lung injury and sepsis, they failed to show a difference on SOFA scores, which was their primary outcome. Those same markers, C-reactive protein and thrombomodulin, were not different. 43 out of their 46 pre-specified outcome measures were not different, except they hit a home run with respect to mortality, which also translated into increase in ICU and hospital-free days. So that was a significant signal in the context of an otherwise negative trial. However, at that time, we also acknowledged that that result was very tenuous or fragile, if you will. And what I'm illustrating here is the fragility of the finding. In the left-hand side of the screen, you have the observed trial results in a 2x2 plot. There were 25 deaths with vitamin C, 38 in the placebo group. And if I just switch one death in the vitamin C, so there's one more death, one more non-death in the vitamin C group, which is I'm illustrating in the right-hand side of the screen, we lose the statistical significance. So that's a way of judging how stable, how robust those trial results are. And so based on, those findings, we're still some uncertainty about the value of vitamin C in sepsis. We still wanted more studies. Again, it looked safe as there were no adverse events reported, but we needed more research. And so with colleagues, I was involved in the LOVEIT trial, which was just published last week in the New England Journal of Medicine, which took the same dosing structure, but now we're talking about sepsis and patients in septic shock, randomized to placebo, and that used the same outcome measure, persistent organ dysfunction plus death. And in fact, they showed worse clinical outcomes associated with giving intravenous vitamin C. 28-day mortality or PODS, which was their primary outcome, a risk ratio of 1.21 with a p-value of 0.01. Now, the rest of those outcomes, where we look individually at mortality and at the components of persistent organ dysfunction, the use of vasopressors, mechanical ventilation, or renal replacement therapy, they're not statistically significant. And actually, this trial result highlights the statistical efficiency of PODS plus death. When you combine the two, then you gain that precision. They showed, looked at a number of other outcomes. There were no significant differences in any of them. There were no differences in the safety outcomes, which we'll highlight throughout this presentation in terms of kidney injury, hemolysis, hypoglycemia, or serious adverse events. They had a number of biomarkers that they looked at and didn't show any difference in organ-specific biomarkers. And so we really lack an explanation as to why the trial showed a tendency towards harm, a tendency towards individual organs that failed, but not significantly in any of them individually, particularly with kidney injury. As you see, stage 3 acute kidney injury was the same in both groups. So when we combine then the LOVEIT trial with the other existing trials of IV monotherapy. So again, these are just trials of high dose intravenous monotherapy. We're now not including trials of thiamine and hydrocortisone because we showed in our prior meta-analysis that those have a systematically different treatment effect. And so if we're trying to summarize the overall effect of intravenous vitamin C, we need to just look at the trials of monotherapy. And whether you're talking about single center trials or monotherapy, single center trials or multi-center trials, we see an overall estimate of treatment effect now of 0.74 that is significantly different than one. So a significant reduction in mortality is still observed in the aggregate data, but certainly the LOVEIT trial causes us some consternation about the efficacy in sepsis. Now that's in sepsis, right? So we have a signal in critically ill patients with sepsis that high dose vitamin C may be beneficial when you look at the aggregate estimate, but the Lovett trial does not confirm this. And so we could get into a discussion about should we use in sepsis, yes or no. But I really want to pivot here and say that that's in sepsis, and we're talking about burns here today, and nobody thinks that burn patients and sepsis patients are the same. And so it's still worthy of exploring the value of vitamin C in burn injured patients. Yes, we saw some new results last week that caused some consternation, but we have a risk mitigation strategy that we'll employ where we'll do an interim analysis halfway through the trial to look for increased harm, much like we did with the Re-Energize trial. If you recall, we were concerned about the signal in critically ill patients that have increased mortality with glutamine, and yet we wanted to explore the value of glutamine in burn injured patients, and we went ahead and did the trial. And halfway through, we looked and had a formal safety interim analysis, which allowed us to continue. And so I will stop here in a minute and just see if there are questions or points of discussion on that evidence base. It is important at this point in the trial that we are in a position of equipoise, that we believe there's uncertainty about the value of vitamin C, and therefore we're going to randomize people. And here's an overview of the study. Again, we're going to go into details of each of these steps or phases of the trial as we go through the training today. But just to say at a high level, we enroll patients as soon as possible from hospital admission within 24 hours, which is different than Re-Energize. You had 72 hours in Re-Energize, but here, as I'll highlight in a later module, it's important that we get the vitamin C going as soon as possible. Once it's started, 96-hour duration of treatment plus 3 additional days of daily collection just to capture some safety outcomes. And then we, again, similar to Re-Energize, we follow patients for 6 months, documenting 6 months survival and the same quality of life and activities of daily living instruments that we used in Re-Energize. So we think VICToRY trial, if it's positive, has the potential to impact morbidity and mortality and improve the recovery of seriously ill burn patients. And it is a cheap, inexpensive treatment. And so it's worth further discussion or further evaluation. So for the rest of today, I will talk some more next about the site investigator responsibilities, patient eligibility and outcomes, and then I'll transition to Maureen, who will take care of the rest of those modules. Now will be a time for any questions. So Maureen, I'll ask you to stop the recording